करने के लिए, जो प्रेजेंट करने के लिए फ्रंट पे आ जाए काइंडली, ताकि स्टार्ट हो सके, लेट ना हो सके फर्दर। डॉक्टर सरमद या डॉक्टर अमजद, आप में से काइंडली कोई स्टार्ट कर ले, या डॉक्टर फहद। डॉक्टर जफदम भी है। डॉक्टर जफदम, आप काइंडली स्टार्ट करें, पहला केस आपसे स्टार्ट करते हैं हम लोग।
So this is the virtual examination preparation for candidates. Voice come karo. Sir, आपको मेरी आवाज आ रही है?
Riaz, I can hear you.
Okay, sir. Sir, you can start. Candidate.
So,
Sir, this is a long case.
Yeah, तो जो कैंडिडेट है जरा पढ़ के सुना दे।
कौन है कैंडिडेट? डॉक्टर असद।
सर डॉक्टर एतजाज करेंगे।
डॉक्टर एतजाज, डॉक्टर एतजाज शुरू करें। डॉक्टर एतजाज।
हेलो, अस्सलाम वालेकुम सर।
वालेकुम अस्सलाम।
वालेकुम अस्सलाम।
I'm the
असद।
जी सर।
असद, डॉक्टर एतजाज कहाँ है यार?
सर ये इधर ये, और
शुरू करें ना।
म्यूट हो गए उनका, आपकी तरफ से कोई म्यूट कर दिया उनको। अब
शुरू करें ना एतजाज।
अस्सलाम वालेकुम सर।
अस्सलाम।
Hello, am I audible?
Yes.
Should I start, sir?
Please.
40 years old female. That is nice to check. Sir, in this female, there's a history of headaches in 6 months and decreased vision for 2 months. First, I will go for the history of headache. I will elaborate. I will ask from the duration. Second, what is the onset? It's insidious or sudden. And radiation, what is the headache is radiate to other side or not? And what is the associated to LVS, like the ICP symptoms of increased ICP, vomiting or thus. And secondly, associated symptoms I can ask from the seizures, and as well as at the same time I will evaluate from the lobar functions as well. If frontal lobe symptoms and the temporal and the parietal, all lobar functions I will evaluate from this one, and the association symptoms as well. Secondly, as the patient has the decreased vision, I will ask from the vision is the partial or the complete, and is the insidious or the sudden vision loss, and second from the one eye or the second both eye or the simultaneously, and what is the site of the visual loss is there, either it's the from the nasal side or the temporal field lesion is there, and this is the association symptoms of the vision. And Hello.
Please carry on.
Secondly, in the relevant history, in the relevant history, I will ask from the past history, past medical history and surgical. If the patient, as the ladies, there is a history of pregnancy or not. And secondly, the OCP history, drug history, and the OCPs are more significant. We can ask from this one and the menstrual history as well. Uh, other systemic examinations, most commonly these are systems, so I'll elaborate from the all the systemic review and the cranial examinations plus higher mental functions and the cerebral lobar functions, and second the pituitary as well, and secondly and the associated symptoms, because it could be because of second I will go for the skull base problems of their nasal relevant examination. I will go the nasal. In the eye examinations, I will do the eye examinations completely, and associated I will secondly I can go for the in the higher systemic examinations cerebral functions. I will evaluate examination that either or not motor and sensory, and the last I will go for the gait.
Okay, so is there anything else in the history that you might want to assess?
History. So secondly, second thing that is I can endocrinologically purpose.
Yeah. So what about the endocrine? You missed out the endocrine symptoms completely.
Yes, sir. Yes, sir. Relevantly in the history, I can ask from the endocrinological history, like.
Yeah. All right. Now, so let's stay with that. And so when you come to the examination, what will you be asking? What will you be looking for, eliciting?
In the examination, most common thing that in this patient, I will go for the higher multifunctional lobar, and second, as the vision is decreased, so I will evaluate the vision totally, visual field and visual acuity. I will do the fundus as well in this patient.
Can you please take us through the relevant ophthalmological examination?
Relevance,
Sir,
sir.
What exactly will you do
Visual
in ophthalmology?
relevant.
What
I will do
you
all examinations. First, I will go for the visual acuity. Then I will do the visual fields. That which visual field is problem. Extraocular movements. I will check of the patient. I will check the extraocular movements. Second, I will do in the last fundoscopy, and I can do the finally the perimetry.
So you're not going to do her pupillary reflexes.
Yes, sir. Reflex. I will do.
Okay. What are the features will you look for in examination, please?
I will the features which I will locate in the examination. I will try to localize the lesion. That where is because where is it? Because I will exclude the pituitary and solar and supraciliary regions and all other regions as well, and the posterior fossa regions. Like if the patient, I will check on the visual acuity and the visual fields most common. And secondly, hydrocephalus is there because vision can be decreased because of the hydrocephalus.
So you think that it's possible that this lady has no tumor, she just had hydrocephalus. That's possible? Is that what you're saying? Yes? Dr. Asad,
Sir,
please unmute yourself. Dr. Asad, please unmute yourself.
सर ये डॉक्टर एतजाज हैं जो डॉक्टर असद का यूज कर रहे हैं, डॉक्टर एतजाज.
Well, whoever it is, can he unmute himself and tell us what he looks like he's frozen.
डॉक्टर एतजाज, डॉक्टर एतजाज.
उसका कनेक्शन फ्रीज हो गया यार.
नहीं सर, कनेक्शन है. एतजाज, डॉक्टर एतजाज.
Sir, hello, sir.
जी.
Hello, Dr. Itzaz here.
Okay, Dr. Saab, sorry, we lost you for a little while. Can you hear me clearly now?
Yes, sir. Yes.
Okay, I want to ask you, you've raised the possibility that the headache and decreased vision in this lady could be because of hydrocephalus. Yes?
Yes, sir.
All right. Now, I want you to tell me that in the examination, what features will you specifically look for to make the distinction between these two diagnoses?
In examinations, in the visual fields, I will evaluate one. I said that it could be because of the hydrocephalus.
Yeah, very good. I mean, that's a very good possibility. Now, I want you to tell me what are the features in the examination would favor one diagnosis versus the other. What would you specifically look for?
Visual acuity is there. If it is the partial visual loss and the papillary edema and the optic atrophy is there, so this can differentiate first thing. This can differentiate the site of the lesion, and secondly, it is the bitemporal heminopia or homonymous henopia, and second, I will check the gait of the patient as well. So by this one, I can differentiate that what is the site of lesion.
What is the field, what is the perimetry finding in hydrocephalus?
Sir, in the hydrocephalus patient will present with papillary edema.
Sorry, I'm not asking you about fundoscopy now. I'm asking you in the perimetry, in the field examination, what are the features of papillary edema versus pituitary?
Pituitary.
In the field examination.
तो उसी तरह
Sorry,
बता
sir.
Riaz?
जी सर. सर ये दो कैंडिडेट हैं, डॉक्टर फरहाद और डॉक्टर साकिब, वो भी अपीयर हो रहे हैं. तो आप अगर एक कैंडिडेट जवाब नहीं दे सकता है तो आप उनको भी ऑनलाइन ले सकते हैं. फरहाद और साकिब. डॉक्टर फरहाद एंड डॉक्टर साकिब, कैन यू हियर अस? ओके सर. सर कंटिन्यू करें सर.
ये वो डॉक्टर साहब पता नहीं कहाँ चले गए.
नहीं सर, I am available sir.
Okay, fine. So can you please answer my question?
Yes sir. Hello sir.
जी बेटा, मैं इंतजार कर रहा हूँ. I'm waiting for you to answer my question. which is on perimetry, which is visual field examination. How do you distinguish between hydrocephalus and pituitary adenoma? Okay, chalo, let's move on. Let's move on. Can I just quickly tell you? क्या नाम एतजाज नाम बताया आपने?
जी सर.
असद नहीं असद का
जी सर,
इस्तेमाल कर रहे हो, नाम क्या है आपका?
सर एतजाज आप जवाब दे रहा है डॉक्टर मेजबीन के लैपटॉप से दे रहा है क्योंकि कोई सिग्नल इश्यूज थे.
यार आई डोंट नो, आप ये हैदराबाद वाले बहुत कंफ्यूज करते हैं, बहुत ज्यादा कंफ्यूज करते हैं. एक बंदा है 3 कनेक्शन लेके बैठा हुआ है यार. अच्छा डॉक्टर साहब, आई जस्ट वांट टू टेल यू कि जो पैपिलोडीमा होता है ना, उसमें देयर 2 features. One is that first of all, I'm not talking about the fundoscopic examination. I'm talking about now the field examination. The first thing is that the blind spot enlarges, and the second thing is that the visual fields constrict in a concentric manner. So eventually they end up having tubular vision. So the answer to the question is that in hydrocephalus, you get enlargement of the blind spot and then concentric constriction of the visual fields. While in pituitary adenoma, this thing, papilledema is never a great feature, but you tend to get bitemporal hemianopia. That's the most classic. But sometimes if the pituitary adenoma is growing towards just one optic nerve, then you get loss of visual field in one eye. ठीक है? Okay, तो ये बात हो गई है. अब आप मुझे ये बताएं, what investigation would you order for this patient?
Sir, after all baseline investigations, I will go for the initially MRI brain plan with contrast. First, before in baseline investigations, I will in baseline investigations I will do the baseline workup, and second endocrinological workup I will do, evaluate the patient.
Doctor Sahab, please. Okay, I'm the patient. I'm in your clinic. Now I want you to tell me कि आप कौन से test लिखोगे. Just rattle them off for me, please. आप पर्चा बना रहे हो. क्या पर्चे बना रहे हो? ये बताओ.
In baseline section, I will go for the.
Don't tell me about baseline. Just tell me कि पर्चे में आप क्या लिख के दोगे. I'm not asking you कि baseline है या bottom line है. Just tell me what are the investigations that you're going to ask me to do. I'm the patient. I'm sitting in your clinic in front of you.
आपने CBC करवानी है, ये टेस्ट है CBC. और उसके अलावा क्योंकि इसमें जो रसोली है उसके
No, you don't have to explain to me. Doctor साहब, please don't explain. Just give me the test के नाम कि आपने ये करना है.
इसके अलावा थायराइड प्रोफाइल, अपने TSH, T3 and T4, LH, FSH and HH, and second the prolactin in the endocrinology workup. X-ray chest, perimetry and fundoscopy, CT scan brain, then MRI brain plan with contrast.
Doctor Saab, I must tell you that if I had come to your clinic and you gave me all these tests, I would probably want to go and I would want to see another surgeon who would be more cost effective in his care. Because how can you tell me, how can you be sure that I don't have a suprasellar meningioma, a tuberculum cellar meningioma? Can you deny that?
No, I cannot.
Exactly. तो मेरे जो T3, T4, TSH, LFH, LH, MH ये सारी चीजें तो जाया गई ना? So anyway, चले let's move on. आप मुझे ये बताएं कि आपका MRI हो गया है, and the MRI is showing that there's a pituitary adenoma. Okay. Now, can you point to, or can you advise me? Okay, so thank you, Riaz. So here's your CT, and let's move to the next one. Actually, Riaz.
Hello.
Gigi. Riaz, can we just back to the findings, please? Your findings on the slide. Okay, fine. वो slide कौन move कर रहा है?
सर मैं कर रहा हूँ.
Who's moving the slide? Okay, so can you just back finding वाली slide पे जो लिखा हुआ है, one back. Yes, please. So here are the findings. Okay, let's move now to the CT scan, please. And असद जरा प्लीज मुझे बताओ इस CT scan में क्या देख रहे हो आप?
So there is a CT scan plan without contrast.
Yes.
That is it's showing some iso-intense lesion well comprised at the suprasellar area, cellular and suprasellar region.
असद ये थोड़ा hyper dense नहीं है?
Iso to hyper, sir, sorry.
थोड़ा hyper dense है, iso से जरा ज्यादा है. Okay, let's can we move and what's your diagnosis here?
That's a suprasellar mass, suprasellar neoplastic lesion.
Yeah, but what kind of lesion?
Sir, the meningioma and the neoplastic in the benign tumor, most likely there could be the meningioma. And to further comment, I need MRI, sir, to locate the site of the lesion.
No, MRI दिखाएंगे आपको, MRI जरूर दिखाएंगे आपको, लेकिन I just want you to tell me कि you think कि अगर you think meningioma है तो दूसरी, but एक और कोई possibility बताओ ना.
It could be a
another
pituitary.
possibility.
Second could be pituitary.
All right, fine, okay. And just between the two, how much percent meningioma, how much percent pituitary probability? Is it 50-50?
No, sir. Most commonly, it's a meningioma.
Okay, fine. All right, let's move to the MRI. Riaz, MRI दिखा दो, please. Now, Asad, please have a comment on this now. इस पे comment करो.
This is the MRI brain plan. On the left side is the T1 weighted. It's showing the ISO2 hypointense lesion is there at the suprasellar area. In T2 weighted, it's a hypointense And the axial view in the contrast is homogeneous enhancements there and well circumscribed region.
Please go on.
On the sagittal sections, there is a T1 weighted. There is a SO2 hypointense regions at the suprasellar area, but it's most commonly on the सेला की थोड़ा सर वो little bit posterior है. The typical सेला पे तो नहीं है, suprasellar नहीं है. And the contrast is enhancing, homogeneous enhancement.
So you think this is atypical? So what possibility अब आपकी diagnosis क्या बन रही है?
Sir, it's a meningioma, sir, most on the top.
Okay, so ये बताओ कि does it make a difference to your further management if this is a meningioma or a pituitary? Because ये दो चीजों की बातें हो रही हैं ना. Does it make a difference to your management, or it doesn't really matter because it's a tumor that has to come out?
Yes, yes, sir. In management plan, it will be different if the pituitary and meningioma. If the meningioma is there, I can go for the angiography as well. But in the pituitary, the management will be the different.
In what way? In what way will the management be different if it is a pituitary, Doctor?
In the pituitary, sir. Pituitary mostly because this is not the typical region of the pituitary. Pituitary mostly it can encase the ICA and the surrounding structures.
Sorry, it can encase the what, sir? It can encase what?
Sir, pituitary, this is the first thing. This is not the typical region of the pituitary. Second, the meningioma, is the vascular tumor. So I can go for the angiography in the meningioma, and it can encase the surrounding structures.
Like which surrounding structures?
Because the territory of the ICA is there.
Yes.
So it can encase the ICA.
Which the meningioma or the pituitary? किसकी बात कर रहे हैं आप?
Sir, meningioma.
So pituitary doesn't encase the ICA, right?
Sir, pituitary less likely.
Okay. Can we move to the next slide, please, Riaz? उस next slide में क्या है?
Sir, can we ask about any grading system of this tuberculum sella meningioma to candidate?
Tuberculum sella grading.
Sir, can you hear me?
I can.
Yes,
I can hear you, Riaz.
Sir, sir, can you ask about the grading scale which is in help in surgery of the tuberculum sella meningioma?
Especially tuberculum sella meningioma, further grading. For tuberculum meningioma, especially the separate grading. Sorry, sir.
So, Riaz, I actually, first of all, I believe that this is a pituitary adenoma and it's not a meningioma. That's what this look. I mean, it's possible. It's possible that this is a diaphragmatic meningioma, but I think that that's unlikely. To me, this looks like a pituitary adenoma. And in this pituitary adenoma, you can see that the pituitary stalk is pushed up, and the normal pituitary gland is lying right at the top of this tumor. And you can see that on the coronal image in the middle here, the pituitary fossa is enlarged, and the floor is bulging into the sphenoid sinus down there here. And these are features that are more in favor of a pituitary adenoma than a diaphragmatic or a tubercular meningioma. So but I'd be interested to hear now if there are any grading scales for suprasellar meningiomas, pituitary adenomas that you are familiar with.
Sir, can you ask this question from Dr. Saqib?
Sure. Is Saqib here? Is he online?
Dr. Saqib, are you here?
Yes, sir, I'm here.
Okay. So now you will continue with because you are also appearing in exam.
Yes, sir. So, sir, you are asking about grading system to classify suprasellar, extent, or parasellar.
No. Now that you're here, I want you to first please describe the MRI images that you're looking at on the screen.
Okay, so the first image on in the top row is MRI brain axial section T1 plane image, which is showing an ISO intense, well circumscribed lesion in the suprasellar area. And in the second image, the T2 weighted axial section, we can see the lesion is ISO intense with a small flow void probably in the middle. Whereas the third image is T1 post contrast axial section, and we can see the lesion is contrast enhancing, and there are some enhancing vessels as well, which can be appreciated within the lesion. The fourth image is a sagittal section, T1 plane image, which is showing that the lesion is in the sellar area and is extending suprasellar as well. Up to the floor of the third ventricle. It is slightly globular in appearance. Posteriorly, it is extending up to the midbrain and pons, and inferiorly, it is bulging into the sphenoid sinus as well. And anteriorly, it is extending up to slightly towards the anterior clinoid processes. The fifth image is the coronal section. And
Saqib, before you move away, Saqib, मैं arrow चला रहा हूँ, वो नजर आता है आपको? ये arrow नजर आ रहा है आपको?
No, sir.
नहीं? Okay. So, Saqib, before you move away from the sagittal image, please tell me what you see on top of the tumor.
You are talking about the stalk, sir?
Yes, I am, sir.
The thin structure that is probably the pituitary stalk, which has been pushed up.
So if you look at the pituitary stalk, at the back, posteriorly, you can see the mammillary process, the infundibulum, mammillary bodies and infundibulum. And then forward, you can see it enlarging slightly, and that's probably the normal pituitary gland.
Okay, sir.
All right. Okay, और बोलें?
Sir, जो pituitary है, sir, there's a one question. ये sella के अंदर, in the floor of the sella, we can see some slight hyperintensity.
Yes, you can.
Is it possible that is the normal pituitary which has been pushed down?
No.
Because stalk is up there.
Because the stalk is up there. And the normal pituitary will be up where the stalk is going.
Right.
So just move to the coronal.
Fifth image, yes. In the coronal image, we can see a well circumscribed iso-intense lesion in the cellular and supracellular area, and we can also see the flow voids of internal carotid artery which have been pushed laterally, and superiorly the lesion is extending up to the floor of the third ventricle, and I cannot very clearly appreciate chiasm on this image.
बट लगता है तकरीबन वहीं पे होगा, chiasm वहीं पे होगा.
Yes.
मुझे भी नजर नहीं आ रहा, लेकिन it's got to, that's where it's going to be.
Right. And the last image is a sagittal post-contrast T1 sequence, and we can see the contrast enhancing lesion. There is some hyper intensity in the sella as well, and the lesion is avidly contrast enhancing, homogeneously enhancing.
Okay, can you just now tell me on this last image?
Yes, sir.
And this observation is for Asad. यार एक तो वो उसने मुझे कंफ्यूज कर दिया कि उसका एतजाज नाम है या असद नाम है.
सर उसका नाम
anyway, candidate number 1 from Hyderabad.
एतजाज.
Yes, तो एतजाज जरा प्लीज आपके लिए ये एक बात करनी है. Saqib, please tell me what is it that you don't see on this sagittal post contrast image. और ये हम एतजाज के लिए बात कर रहे हैं.
Right. So we cannot see the pituitary gland enhancing.
No, we don't see a dural tail, Dr. Saab.
Right.
Yes, sir.
There's no dural tail आगे, there's no dural tail पीछे.
जी.
So that's एतजाज very important point against meningioma and for pituitary adenoma.
Yes, sir.
Okay. रियाज आगे फिर कहाँ चलना है?
जी सर, ये साकिब या फराज में से आपको आगे आ जाए. सीपीएस की जो है आजकल एग्जामिनेशन में एक न्यूरो एनाटॉमी की जो है पिक भी जो है लगाते हैं. तो सेकंड आवर क्वेश्चन विल बी ऑन दी न्यूरो एनाटॉमी पिक्चर. सर स्टार्ट करें आप सर.
शोर बहुत आ रहा है किसी के माइक से.
एक्चुअली सबसे रिक्वेस्ट है कि प्लीज सिर्फ कैंडिडेट का स्पीकर ऑन हो, बाकी सब म्यूट हो जाएं प्लीज. बाकी सब लोग अपना म्यूट बटन दबा दें. थैंक यू. जी कैंडिडेट्स.
साकिब या फरहाद, इनमें से कोई जो है आगे आ जाए और स्टार्ट करे.
जी सर. सर मैं सर स्ट्रक्चर ए वो सीम्स लाइक ऑप्टिक नर्व है सर, और ऑप्टिक ट्रैक्ट है सर, और जो बी में मार्क किया हुआ है इट्स ऑक्लूटर, एंड द सी इज मेमोरी बॉडीज, एंड द डी इज bones, and while this terminal nerve, and E is spinal cord sir.
और F भी है.
Seems like sir vestibular complex 7, 8 complex.
बहुत ज्यादा मोटी है.
F can be trigeminal.
सर F ऊपर वाली जी सर, F is trigeminal nerve सर.
अच्छा, आपने D को जो है E को जो कहा स्पाइनल कॉर्ड, तो ये स्पाइनल कॉर्ड तो नहीं लग रही है क्योंकि अभी तक
सॉरी मेडुला ऑब्लोंगेटा.
मेडुला ऑब्लोंगेटा का कौन सा पार्ट?
सर लोअर पार्ट सर.
नहीं, इसका नाम क्या है
सर? पिरामिड सर.
सर आप कहाँ हैं?
सर डॉक्टर वहीद सर।
नहीं, जुमा साहब कहाँ हैं सर?
जी रियाज।
जी सर, कंटिन्यू करें ना सर आप।
या नहीं, वो वेटिंग के वो आपका एनाटॉमी खत्म हो जाए।
ओके। कोई और वॉलेंटियर जो ई को जो है एलाबोरेट करे, ई का ई जो है वो पार्ट बताए मेडुला का।
pyramid or trach? Similarly, pyramidal parts.
Sir, can I say?
Yes, you can.
Sir, E is pyramid.
Good. This is the pyramids. ठीक है ना? Bulging part of the medulla is the pyramid. और जो डी जो है, डी भी आपने बताया पॉन्स, लेकिन आप देखें ये डी जो है एब्ड्यूसेंट नर्व है ये।
यस सर।
तो हम आगे मूव करें।
तो रियाज ये माजिबीन जो है कैंडिडेट है कि नहीं?
नहीं सर, ये कैंडिडेट नहीं है।
क्या तुम उसको छोड़ नहीं रहे इसलिए?
सर आगे मूव करें एनजीओ पे
प्लीज।
ओके सर,
प्लीज। ये कैंडिडेट कौन है रियाज?
कैंडिडेट सर साकिब, फरहाद, एतजाज, मैजबीन सारे ही हैं।
अभी इस सेगमेंट के लिए आगे कौन आएगा?
फरहाद आप कहाँ हैं? जो भी वॉलंटियर हो वो आगे आ जाए, जो एग्जाम दे रहा है या जो इंटरेस्टेड है।
जी सर।
क्या नाम है आपका?
सर मैं कर सकता हूँ?
आपका नाम क्या है?
सरमद, डॉक्टर सरमद, रेजिडेंट न्यूरोसर्जरी।
ये रियाज, दिस इज डॉक्टर सरमद फ्रॉम आगा खान।
ओके सर, वेलकम डॉक्टर सरमद।
Okay, so Sarmad, so you can see highlighted A, B, C, D, and E, and you can please take us through what these features are.
So the structure marked A appears to be the N2 segment of the middle cerebral artery on the right. B, if it's the bigger one, is the A1 on the right. E is the internal carotid artery.
Sarmad,
मैं एक स्लाइड मिस कर गया हूँ, पहले एक स्लाइड है उसके बाद। जी सर, ये स्लाइड है सर।
Oh, okay, all right. ठीक है, चलो हो गया। All right, let's go back to the angio. So ये सरमद, ये जो एंजियो है, वो जो प्रीवियस पेशेंट का स्कैन हमने देखा था वो चीज है, उसमें क्या नजर आ रहा था? राइट, और ज्यादा इंटरहेमिस्फेरिक फिशर में था ना, यही था? Am I right?
Yes sir.
All right.
Yes sir.
Okay, अब और बताओ। अब take us through the structure marked middle cerebral बोल रहा है।
So M2 segment कर रहा है।
Okay, और
of the middle cerebral artery, B would be the A1 on that side. Of the first segment of the anterior communicating, E is the internal carotid. The structure marked C is the anterior cerebral artery. D, if it's the structure that they've identified, appears to be an aneurysm of the anterior communicating artery. D, I mean, D appears to be an aneurysm of the anterior communicating artery.
Yeah, okay. And can you say something about that aneurysm? मकसद कहने का ये है, is the aneurysm pointing in any direction? Is it?
So it's hard to tell just from this one projection. I would like to see further projections to see which direction it's pointing to, but it's a little difficult to tell. It appears completely round in this projection.
Yeah, okay.
So it may be pointing towards us.
Yeah, good. No, that's fine. That's the answer, Sarmad, that you can't make a judgment on the direction on just one projection. And you will certainly need to see a lateral, but you may also want to see an SMV to be able to clearly define. The other thing, of course, would be to get a CTA where this feature would be better seen. ठीक है यार, ये सरमद का तो ठीक था यार।
जी सर। सर ये क्वेश्चंस पूछ लिया आपने? व्हाट आर द अप्रोचेस टू दिस aneurysm.
नहीं, ये तो फिर आप पूछो ना इसको.
Okay. So Dr. Sarmad, what are the approaches for this aneurysm?
The current strategies.
Okay, current strategy.
So the available modalities for treatment are either surgery or endovascular treatment. Endovascular can include coiling, stent-assisted coiling, or a flow diverter, pipeline embolization device. And for surgery, the standard of care is surgical clipping.
Sarmad, please. अब ये I accept कि जो इसमें 4 bullet points लिखे गए हैं are not written very well, but please look carefully. पहला जो था was about the angiogram. The second is management, and management is more than surgery. This patient has had a subarachnoid hemorrhage. This patient may have other problems. If you look at the angiogram, एक चीज जिस पे आपने ज़्यादा गौर नहीं किया, but I didn't stress it either. But ये anterior cerebral की कुछ displacement भी लग रही है. So there's probably some brain swelling going on. So first he's asking you to the management, and the third question is approaches to the culprit or the lesion. Rather than culprit, I would say lesion. वहां पे आप बोल सकते हो कि यार मैं ये करूंगा. पहले तो वो मैनेजमेंट का पूछ रहे हो तुमसे ना. तो the candidate रियाज, तुम खुद ही बताते हो कि ज्यादा कैंडिडेट फेल होते हैं क्योंकि वो सवाल या तो पढ़ते नहीं है या सुनते नहीं है.
जी सर.
एंड सरमद ने पहले बुलेट पॉइंट का इतना अच्छा जवाब दिया, बट सेकंड बुलेट पॉइंट में वो बिल्कुल ही गोल कर गया. तो जो उसने अच्छी बात कही है, ही इज बीन ब्रॉट डाउन नाउ, बिकॉज रादर देन टॉकिंग अबाउट द ओवरऑल मैनेजमेंट, वो सीधा सर्जरी पे चला गया, वो लीजन पे चला गया. लीजन का तो तीसरा बुलेट पॉइंट है. और फिर अगर वहां पे भी आपने कहा कि जी इसका एंडोवैस्कुलर सर्जरी है, फिर वो आपसे पूछेगा कि अच्छा सर्जरी का बताएं आप. That's the flow, that's the sequence, that's the flow.
डॉक्टर सरमद, आप बताएं कि आप मैनेज कैसे करेंगे पेशेंट को.
Let's go bullet point.
So this patient needs to be admitted in an ICU, preferably a neurosurgical ICU. He needs to be monitored at least hourly neuro checks. His GCS needs to be monitored as well. He needs to have a Foley placed for intake and output monitoring. His blood pressure needs to be tightly regulated, and his MAP needs to be maintained between at least 120 and 100 to prevent ischemia from vasospasm. And he will also, once he's stable, I don't know if this is a male or female patient, once the patient has been stabilized, if this is the only injection we have from the DSA, he will require a complete he or she will require a complete 4-vessel angiogram before we can plan further care.
डॉक्टर साहब, इसके कोई ब्लड टेस्ट करेंगे आप?
जी सर, he will require CBC, electrolytes, magnesium, one creatinine especially because he's going to undergo angiograms, and he also needs a serum lipid profile, and other than that he needs a chest X-ray.
So इसका lipid profile, how will that help in his management? This is management
so,
of the
it does not. There's some it doesn't really help. You're right, lipid test doesn't help.
और CBC में क्या देखेंगे आप?
CBC में hematocrit is important, the hemoglobin and hematocrit.
Okay, very good. All right. और electrolyte में क्या देखेंगे?
Electrolyte means the sodium and potassium levels are especially important.
Why is that?
Because patients with subarachnoid hemorrhage often have problems with sodium homeostasis, and this can include hypernatremia or hyponatremia.
What kind of problems do they have?
They can have cerebral salt wasting, or they can have cerebral salt wasting or SIADH, even DI in certain cases.
Okay,
and
so that's what I wanted to come to.
to.
And this thing that you pointed to is particularly common in aneurysms of the anterior communicating artery, because it's right next to the controlling zone.
Yes.
तो ये तो तुमने, जब मैनेजमेंट की बात होती है ये तो आपने स्ट्रेस करना है ना कि मैं उसकी सोडियम्स करूंगा, उसकी ऑस्मोलैरिटी करूंगा और रेगुलर सोडियम की चेक करूंगा. Then you tell then the examiner knows कि यार तुमने कभी मैनेज भी किया है सबरेक्टल हेमरेज का पेशेंट, एंटी कम्युनिकेटर का पेशेंट. चलो, any more question, Riaz? Any more questions on management?
Dr. Sarmad, what are the complications after subarachnoid hemorrhage?
Should I just list them? Patients can have vasospasm following subarachnoid hemorrhage. And vasospasm can lead to ischemia, stroke. Another complication is a lead. Hydrocephalus can also occur.
Okay, ठीक है. So आगे पढ़ें. What are the approaches to this lesion?
Riaz, just 1 second. Okay. Riaz, 1 second. So just tell me what is the incidence of vasospasm in subarachnoid hemorrhage, acute subarachnoid hemorrhage?
So it depends on the amount of blood in this.
तो इस पेशेंट का बताएं. Okay, Riaz, sorry, Sarmad, I wanted you to note that compared to his middle cerebral, the anterior cerebral and the distal anterior cerebral are in spasm. Compare the anterior cerebral circulation with the middle cerebral circulation. The anterior cerebral circulation is in spasm. So even if this patient is perfectly well, इसका risk of vasospasm is high. तो आप खास तौर पे उस पे आप गुफ्तगू करेंगे कि जी I'm not sure how much amlodipine helps, but it has been used, and I would certainly start that because this man is at risk. तुम ऐसी बात अगर करोगे तो फिर एग्जामिनर बोलेगा हाँ यार थोड़ा बहुत तो एटलीस्ट एंजियोग्राम का पता है. So always look at the caliber of the vessels where the aneurysm is, because that gives you the hint कि जी वो spasm है या नहीं. चलें जो उस पे अच्छा. And just going back to the blood tests, I see somebody in the chat has pointed out, and he's absolutely right. You should always have said that you do a coagulation profile, bleeding, the APT, APDT, and stuff like that. You should. I know that you would always do it, but you need to also have it at the top of your mind, so you say वो तो आपकी ज़बान से वो बात निकल आए. ये नहीं कि वो आपके ज़हन में रह गई है. I mean, because ये तो आप करते रहते हो तो आगे बताने की ज़रूरत नहीं है. ऐसा नहीं करना. Are you with me?
Sir, ये approaches मैंने इससे पूछी थी. What are the approaches to this lesion?
Yeah, Riaz, Sarmad seems to have disappeared. कोई और candidate पकड़ो.
Okay, sir. कोई भी volunteer हो आगे आ जाए. Next उसके लिए.
ये is Dr. Sami a candidate?
Dr. Sami. Is
Dr. Sami a candidate? नहीं.
Anybody interested from other sides?
सर लो वॉल्यूम का एग्जाम मैं कर लेता हूं सर.
नहीं, एक मिनट पहले उस रियाज उस स्लाइड को खत्म कर दो प्लीज यार.
जी सर.
Back slide, back one. Yeah.
Okay, sir.
Now, somebody in the chat is writing stereon. That's not what the examiner is asking you. That is his next question. At the moment, he's asking what's the approach to a ruptured aneurysm. इसमें आपने बात करनी है about surgery versus coiling and so on and so forth. यहाँ पे वो बात करनी है. फिर next जो है, अगर सर्जरी का डिसीजन होता है, what are the steps of the surgery, वो आप कह सकते हो कि मैं टीरियन करूंगा या मैं इंटरहेमिस्फेरिक करूंगा, जो भी है. ठीक है. So right, okay, रियाज बस लेग्स पे चलो.
कौन करने जा रहा है? Who is volunteer?
सर मैं कर रहा हूँ सर.
क्या नाम है आपका?
सर फरहाद.
फरहाद किस सेंटर से हैं आप?
सर लियाकत नेशनल हॉस्पिटल.
ओके, गुड फरहाद. डॉक्टर जुमा इज हियर और वो आपसे पूछेंगे.
तो रियाज, फरहाद जरा जस्ट प्लीज अपनी जबान में, उर्दू में कहें अंग्रेजी में कहें, दैट डजंट मैटर. आप जस्ट बताएं कि जी आप अगर आपको एग्जामिनर ऐसा बंदा दे दे और कहें एग्जामिन द लोअर लिम्स, तो आप किस तरह करोगे, क्या सबसे पहले क्या करोगे, फिर अगला क्या करोगे, फिर अगला, ऐसा बता दो.
जी sir, first of all I will greet my patient. I will ask his name and I will explain the procedure which I am going to perform, and then I will take consent. And I will ask from the examiner the proper exposure and then till the umbilicus. Then in the lying position, I will start with my inspection. I will see the lower limbs, the grossly how lower limbs are. Any there is any scar mark, is there any visible veins or any pulsation, and then I will start with the palpation. And in the palpation I will see the tone at the hip joint, at the knee joint, and at the ankle joint. And then I will see the fasciculation, and then I will check his LR and will do if he has power in the limb. Then I will check the power at proximal joint, at the hip joint, hip extension, hip flexion, hip adduction, hip abduction, knee flexion, knee extension, and dorsiflexion, plantar flexion, and EHL, big toe dorsiflexion and plantar flexion, and also inversion and extension. After doing the power assessment, I will go for the reflexes at the knee joint and at the ankle joint, and also I will check the plantars, and also if the plantar are upgoing, then I will check the clonus. And after assessing the reflexes, I will ask the examiner for examining the perineal sensation, and also the perineal sensation, and also will also check the system while wearing it at the level. After I will ask the patient to feel if if he or she is feeling from the top, and then I will compare at the lower limbs dermatomes. At between the first wave space is the L5, and on the lateral side of the foot is the S1, and on the medial malleolus it is L4, and above the knee joint is the L3. At the mid thigh is L2, and the mid inguinal ligament is L1. After completing the sensory examination, I will ask the examiner for relevant examination. If I am getting any sensory level, then I will also check the abdominal cutaneous reflexes, and also check the upper limbs, and also will check the upper limb reflexes. And also I will check the back, and also I will check the tenderness, if there is any tenderness, any gibbous, or there is any deformity. And also I will then I will ask to stand, and also I will check the gait. Also I will check the Romberg sign, and I will ask patient to walk on heels and tiptoes, and also do a tandem walk.
Okay. So Riaz, just can we go back? Can we just stay with that slide? Farhad, that's very nicely done. I like that. Farhad, it's always very useful to be able to do. I'm sorry, ये echo पता नहीं कहाँ से आ रहा है. To do when you're doing the palpation. ये वहीद साहब अपना माइक्रोफोन बंद कर सकते हैं प्लीज. वहीद साहब अपना माइक्रोफोन बंद कर लें प्लीज. ओके फाइन. So उसमें in the so we do palpation, percussion, and so on. So the palpation, which is the first bit, is the one where you really should also show that you will use a tape measure to compare bulk. Which was the one thing that you omitted, because agar iska bulk ka difference hai, it's going to be a very subtle difference at the this thing. The other thing again, I just my inspection palpation inspection pay. When you inspect, you should have mentioned that you will inspect the position of the leg and the foot to see if there's any eversion, because जो weakness होती है तो उसमें foot की eversion हो जाती है. And so that's you've done a nice job, but that would also be nice if you mentioned that. Baki, you've done a good job. Yeah, and Tahir is asking us whether we should do joint position sense. So that's possible, but when you're doing a local examination like lower limbs, then the indication is that this is a local phenomenon rather than something that's related to larger CNS issues. But when you're doing sensory examination, there's absolutely no harm in throwing in the joint position sense with the pinprick. I agree with that. Riaz, any comment? I think Farhad did a good job.
Particularly in this patient, I think the second picture shows the weakness in the right-sided foot. So they should inspect very carefully regarding the foot drop. And I have, sir, given you, send you the questions and answers. So,
yeah, sure.
So you can ask from them. We have made.
Yeah. Okay. So Farhad, are you still there?
Yes, sir.
Okay. So the issue that now वो जो side वाला जो image था या नीचे वाला image था, उससे foot drop का पता नहीं लग रहा था. But obviously, when you examine, वो foot drop आपके सामने होगा, right? So now the question really is कि foot drop की हमें जो आपने जो देखा है, give me the most important cause of foot drop that you've seen.
These non-neurological causes.
No. Please listen to my question, Farhad. What is the most common that you have seen? So now I know that you're not a neurologist, so मैं non-neurological तुमसे पूछ ही नहीं रहा.
Sir, it can be due to spinal pathology and it can be due to brain pathology.
No. Farhad, please. Once again, my question is, and please listen carefully to the question. In your observational experience, what is the most common cause of foot drop that you have seen?
Lumbar disc herniation.
Absolutely, yeah. That's the answer to this question. Because हम लोग तो ज़्यादा ये देखते हैं ना. Then the next question is, so now are there any non-radicular causes of foot drop that you can talk about?
These are common causes, the diabetic neuropathy, sir.
Yeah, plus minus, yeah, maybe, or.
And sir, it can be caused in the brain due to any lesion in the medial side of the frontal lobe.
Okay, that's good. But how will you make a difference between a root lesion and that?
Sir, there will be no radiculopathy in the brain lesion, sir. And there will be upper motor neuron sign in the lower limb. The plantars can be upgoing. There can be pronated drift. Reflexes can be brisk.
Yeah, sure. So that's the brain also presents with a foot drop, but it's a different kind of foot drop because that's actually, quite frankly, it's a very stiff foot. Uski tone बहुत ज़्यादा होती है. वो पंजा बिल्कुल हिलता नहीं है, and as you say, उसके plantars upgoing. But what about peripheral nerve lesions? What about peripheral nerve lesions?
Then there can be EMG changes if there is any peripheral.
No, peripheral nerve causes of.
Sir, can be due to like neurofibroma or schwannoma in the nerve root, involving the nerve roots.
Yeah, but this other things like perennial nerve lesions, and
sir, there can be yes, sir. There can be of trauma like fibular head fracture in the trauma.
Yeah, and specifically वो जो होता है ना वो न्यूरोलॉजिकल कंडीशन होती है डिजेनरेशन की, उसमें फुट ड्रॉप होता है. बट coming back to think, can S1 lesion, can an S1 lesion cause a foot drop?
No sir, S1 में sir usually sir plantar flexion sir effect होती है sir, तो उसमें sir इतना नहीं होगा sir.
Yeah. So if you see, if you see what on the MRI looks like an S1 L5S1 disc causing a foot drop, then it's a problem of lumbarization or rather sacralization of L5, and that's why you're getting this. तो लग रहा है कि वो sacrum है S1 है, but actually वो L5 है. आप समझ गए मेरी बात ना?
Right sir.
Okay. Okay, Riaz, can we move to the next candidate and next?
सर इसी से जो है related एक image है, वो दिखाएंगे आप?
Yeah, please.
जी.
Sir,
Okay, so who wants to volunteer on this MRI?
Sir, I want to comment, sir.
Please.
Sir, this is MRI lumbosacral spine, T2 weighted image, sagittal images showing degenerative lumbar spine, and also the disc space at the L4-5 and L5S1 is reduced, and at the L4-5 we can see, appreciate that the canal is stenosed on the sagittal image, and also there is hypointensity at the hypointensity of the ligament of flavum, most likely showing hypertrophy of the ligament of flavum, and also there is disc bulge posteriorly at the level of L5 and S1. While in the axial images, we can see that the on the top, right top, we can see that the canal is stenosed and lateral are stenosed. And while commenting on the image below, there is severe stenosis of the canal.
Yeah. So if this patient were, if this, I beg your pardon, if this scan were of the patient that you saw on the last image, Riaz, can you just go back? Yes, thank you. That one. Now, this patient, as you can see, has a right foot drop. Okay? Now, let's go back to the MRI. How will you correlate this foot drop with this image?
Sir, because the stenosis at the L4-5 nerve root is involved is L5. But on the basis of history and examination, I will ask the history that whether he has a pain on the left leg or not. If he has a no pain in the left, because the is not showing the not correlating with the findings of the examination. The right only right foot drop, because इसमें सर stenosis के ज़्यादा symptoms होंगे क्योंकि canal पूरी compromise है दोनों तरफ से.
Yeah, Farhad, आप सही कह रहे हो. That's well done. So this is one of those situations. This is one of those situations in which you would ask for a EMG, because you want to see whether it's just one root, which is or one radical, which is denervating, or is it more extensive than that? Which would then point to in another direction. So,
sir, can I ask one question?
जी please.
कभी-कभी मुझे भी याद है जब हम रेजिडेंट थे तो एक पेशेंट कंफ्यूजिंग था, तो आपने सीटी माइलो करवाया था, तो उस वक्त आपने बड़ा स्ट्रेस दिया था कि सीटी माइलो में जो है जो बहुत ज्यादा फार लेटरल डिस्क हैं वो आ जाती हैं.
Absolutely. So Riaz, even now I use a CT for far lateral disc, because I find that you see there's some features of the far lateral disc which are a little confusing or missed on the MRI, जो CT में ज़्यादा नजर आता है. तो अभी मैं करता हूँ.
Okay.
तो फराद ने तो अच्छा किया है. फराद, ये आपका पहला अटेम्प्ट है ये?
नहीं सर, दूसरा है सर.
Dr. Farhad,
I hope you do better.
जी सर.
What are the types of surgery you offer to the patients?
Sir, I will again ask the history and examination, क्योंकि मुझे history के basis पे कुछ और इसको
strategies.
Sir, treatment में sir, I will offer decompressive procedure and जिसमें हम laminectomy और disectomy sir करूँगा sir इसमें sir.
What are the different kinds of these procedures? Disectomy.
Sir, disectomy में sir micro disectomy है sir, standard disectomy है sir, और minimally invasive endoscopic surgery है sir.
Okay, good. ठीक. Sir, कुछ comments finally आपके regarding this today's mock and long short cases and these all scenarios and the performance of the candidates. One by one, sir, for Atizaf.
So, performance of the candidates, you know, I don't want to make any comments on that. I just want to make general comment, which is के
sorry sir.
जी.
मेरा एक सवाल है सर. सर ने बताया, मैं डॉक्टर समीर इमाम, कि हम सीटी माइलोग्राम करते हैं फार लेटरल डिस्क के लिए. सर, मैंने अपने लिए सीखना है, ये किताब में कहीं पढ़ा था कि माइलोग्राम तो इंट्राकैनालिकुलर पैथोलॉजी दिखाती है, अगर ब्लॉक वगैरह हो तो अपने पैटर्न दे देती है, लेकिन जो फार लेटरल जो कैनाल से बाहर है उनका सीटी माइलोग्राम पे कैसे पता चलेगा सर?
नहीं तो डॉक्टर समी बोल रहे हैं?
जी सर, जी सर.
हाँ, वो समी डॉक्टर रियाज ने जो इशारा किया था, I do CT myelo for other things, but you're absolutely right.
Oh, okay.
For far lateral, the myelographic component is not that important. You're right.
ठीक है.
So let me just come back to my comment. My comments are that, yeah, you know, the candidates are all, I think, prepared and they know. Lekin, they need to be a little careful in offering a diagnosis upfront when the situation is not very clear. And for instance, in that first case, Dr. Saab, पहले वो सोच रहे थे कि ये पिट्यूटरी है, but वो फिर जोमा की तरफ चले गए और फिर वहाँ फंस गए. And you know, and I understand that, because you know, when you say something, then you don't want to suddenly say, no, I've changed my mind. मतलब ऐसा वो तो जरा बुरा लगता है. So it's better not to say anything in the beginning unless you're forced to. मतलब यानी कि ये जो चीज है ना कि आप अपना वो दो, वो अपनी राय दो या अपना वोट दो कि ये कौन सी चीज है, that the examiner should pull out of you. You should just be talking non-specifically. You should talk about sellar and suprasellar lesions, extending up to the cavernous sinus but not extending into it, extending up to the chiasm. So you try and prolong the discussion in that way, not by just saying कि जी मुझे तो ये लग रहा है ये मेनिंजियोमा है. अब आप वहां अगर फंस के अब एग्जामिनर को एक ही रास्ता है. He has nowhere else to go. He says meningioma. अच्छा, now वो उस पे आपको घूम लेगा कि आप इसको meningioma जो कह रहे हो, इसका जैसे रियाज ने कहा, please give me some kind of classification for suprasellar tubercular meningioma and ऐसे हैं meningioma की classification. आपका they're not very commonly known, so आप फिर कहाँ जाओगे? So you need to be very careful. Don't offer a specific answer, but try and keep the discussion general. That's my Riaz, that's my advice to the candidate.
Sir, इस तरह से भी कैंडिडेट कह सकता है कि ये स्कल बेस्ड ट्यूमर मुझे लग रहा है और वो फ्रंटल या इस जगह पर है, तो वो सेफ हो सकता है.
या बिल्कुल यार,
कि वो डायरेक्ट जो है ये कह दे कि ये सुप्रासेलर है या पिट्यूटरी है या मेनिंजियोमा है, उसको ये कहना चाहिए कि मुझे ऐसा लग रहा है कि ये स्कल बेस पे कहीं मास है जो ऑप्टिक नर्व्स को भी कंप्रेस कर रहा है और हेडेक भी कर रहा है और ये सिम्टम्स दे रहा है, तो उससे ज्यादा सेफ हो जाएंगे.
राइट
सर, बाकी जो साकिब हैं, फरहाद और ये एलएनएच के,
साकिब तो खैर बहुत छोटे टाइम में आया था, एंड सरमद तो छोटे टाइम में. Both of these gentlemen I know well because they're both Khan candidates, and I think that they're both prepared. I just think I'm the person that I worry about. I'm not too worried about Saqib because quite frankly, Saqib last time भी got through नहीं हुआ था, तो मुझे इतना उसका गम नहीं हुआ था because I felt that यार he's a good candidate, ये बंदा eventually pass हो ही जाएगा. I think maybe the examiner didn't like his beard too much or something like that. So by the next time जो है वो बंदा pass हो जाएगा. Sarmat ka, I'm a little worried. Hello. Yeah, I'm out. Sarmat ka, I'm just a little worried because Sarmat, unfortunately, thoda zara pressure mein aa jata hai. Sarmat is one of those people who takes life very seriously, and for him, being rejected by an examiner is a grave kind of not an insult, but a hit on his personal self-esteem. If examiner says you're not passing, Sarmat would feel that there's something terribly wrong with him. Whereas ऐसा है नहीं. मकसद यानी कि you should be in the same situation. यार क्या fail करेगा ना? कितनी दफा fail करेगा यार? मुझे तो अपनी चीजें आती हैं. I know I'm this thing. I've satisfied my attendings and my consultants, and so अपने आप पे pressure ना लो. Don't, because when you go into that thing, then you end up saying things and doing things which are not in your interest. So for Sarmat, my advice really is that he should learn to not take this too seriously, because I've seen के मतलब मैंने कि eventually इन इम्तिहानों में बंदे पास हो ही जाते हैं. एक बहुत मशहूर केस था रियाज, इंग्लैंड में FRCS न्यूरोसर्जरी में एक बंदा था जो मेरे ख्याल है कोई 8-10 दफा उसने अपीयर हुआ और सब लोग उस पे हंसते थे, बट इवेंचुअली 10वीं बार वो पास हो गया. मतलब इनके कितना रोकेंगे आपको यार, वो कितना रोकेंगे? So I don't take this seriously. Everybody who's looked at this examination knows that there is an X factor in this examination, and that X factor you can't control, and that may be a language barrier, it may be because you misread the direction of something, but that's the X factor. Now obviously you want to minimize the X factor, but agar wo X factor aapke khilaf jata hai, it's not the end of the world. Yeah, they're doing 3 examinations a year now. What the hell? So Sarmat, I hope you don't mind my saying these things about you in public, but try to approach this as if there's nothing riding on it. कुछ नहीं है यार, तेरा क्या बिगाड़ेंगे ये लोग? All right?
मैं समझता हूँ आपके वर्ड सर इनके लिए बहुत ज्यादा जो है ना मोटिवेशन है, और इनको वाकई समझना चाहिए कि जो आप कह रहे हैं, इतने एक्सपीरियंस्ड और इतने सीनियर जो है न्यूरोसर्जन जो कह रहे हैं, तो इनको इन बातों को समझना चाहिए और डेफिनेटली अपने आप को इम्प्रूव करना चाहिए, और द डे विल कम व्हेन दे विल पास, और ये सब चीजें भूल जाता है इंसान. सो सर थैंक यू सो मच सर आपके टाइम देने का और
most welcome Riaz,
करवाने का.
most Riaz, and good luck to all the candidates.
Yes sir, thank you sir, thank you. Okay sir, and thank you all.
Save के दिन भाई, recording stop.